Okay, hi everybody. My name is Ikuyo Yamaguchi. I'm a chief of pediatric nephrology at Oklahoma Children's Hospital and OU Health. And then thanks for participating in my talk. My title of my talk is Pediatric Hypertension and Cardiovascular Health. I will start talking, and if you have any questions, and then place in the chat so we can discuss afterward. So let's start. Okay, so here's the outline of my talk. First, I will discuss the definition and variation of pediatric hypertension. And the second, impact on cardiovascular disease. The third is about management of hypertension. And then briefly touch on clinical research in the United States. So let's start. So I'll start with a simple case scenario. A 13-year-old male is at your clinic for annual checkup. He is healthy with no concern or complaints. His growth parameters are height 162 centimeter, 66th percentile, and then weight 70 kilogram, 99th percentile. His BMI is 27, which is 97th percentile. His blood pressure was 132/75 by manual readings on his right arm, and he returned to clinic 2 more times to check his BP, and his BP reading were 135/75 and 129/84. I'm sure you're going to encounter such a case millions and millions of times. And then, so the question is, is his blood pressure normal? That's number one. And if he has elevated blood pressure, what is the likely diagnosis? Does he have any end organ damage? How will you treat him? Will he be hypertensive as adult? Is he at high risk for cardiovascular disease? And before answering these questions, I would like to show some data about cardiovascular disease in adults. This graph shows a major causes of death in the US in 2019, the dark bars, and 2020, the light gray bars. The leading cause of death was heart disease, followed by cancer. The COVID-19 and myriad added to the list in 2020 became the third leading cause of death. Unintentional injury includes falls, motor vehicle accidents, and poisoning. So this US map shows an age-adjusted death rate of each state of per 100,000 people for cardiovascular disease in 2016. So this is a bit old, but as you can see, so that the blue one is a higher death rate per 100,000 population, and the red is less. You can see that Oklahoma is in blue with other southern state. So that our state has a high rate for mortality related to major cardiovascular disease. So these slides show the healthcare cost of the leading diseases worldwide. The cardiovascular disease account for 1/3 of all cause mortalities worldwide and a cost of $100 billion. And as you know, the hypertension heart disease begins in the youth. So this slide shows the several major disease conditions in US children. The prevalence of hypertension is increasing in part due to the obesity epidemic. Now 5 to 6% of children under age 18 are diagnosed with hypertension. An additional 10% of children and adolescents have elevated blood pressure. So this is a big deal for disease prevalence in childhood. So I guess this is a question first. What causes the primary hypertension? And it's a multifactorial disorder resulting from genetics, epigenetics, and environmental influences. The primary hypertension used to be a lot less common in children. The genetic factors influence the susceptibility to primary hypertension, but seldom caused hypertension in children in the past. However, now the primary hypertension is a major cause of the cases, which suggests that obesity and other environmental factors play a major role. This slide shows how increased BMI is associated with elevated blood pressure. The student with BMI greater than 97 percentile has significant increase in the prevalence of pre-hypertension and the stage 1 and the stage 2 hypertension. You can see on the very right side of the graph. So in obesity, there are so many people investigating how the obesity affects the hypertension. And in obesity, adipocytes change their release of several hormones and inflammatory mediators. And this produces the triple hit leading to hypertension. The three main target areas affected are: one, the brain center, regulating CNS output. You can see on this picture, the increased CNS affected hypertension, but increases arterial vasoconstriction, and then also increased endothelial dysfunction. And the second is the kidney. Adipocyte increases angiotensin of them, and then increases renin-angiotensin aldosterone systems, and then increases the Ang2, leads to hypertension, and then also increases the sodium reabsorption volume overload that leads to hypertension too. The third is the blood vessel. Increases of the cytokine release, increases inflammation, that leads to reducing the NO, increases endothelin 1, and that leads to endothelial dysfunctions and arterial vasoconstriction. So that's sort of a current theory. There's so many studies going on right now. As you probably all know, this is the published from American Academy of Pediatrics as the first clinical practice guideline, CPG, for screening and management of blood pressure in children and adolescents in 2017. Because it's been already 7 years. This was updated to the initial 2004 guidelines previously published by National High Blood Pressure Education Program Working Group. And then 15,000 articles published after 2004 were reviewed, and the 30 key action statement and the 27 additional recommendations were stated. In the next few slides, I will talk about the BP categories and evaluation. So there are several key updates. It's been several years, so you're probably familiar with this. The first update from 2004 was adolescents, 13 to 17-year-old. The BP category threshold value are no longer percentile based, but instead matched to the adult AHA and American College of Cardiology adult hypertension guidelines. So 13 or above is the same as the adult guideline. And that makes it a lot easier our practice as well. And the second, the normal intensive BP tables based on age, gender, and then height were revised, and to include only the auscultative blood pressure measurement from normal weight children rather than previous normal data that include overweight obese children. So the number of the references actually got lower because elimination of obese and overweight children. And the third, the threshold value definition stage 2, hypertension for 1 to 12 years old, now a change from a 99th percentile plus 5 to a greater than 95 percentile plus 12. And then we used to use a category named pre-hypertension, but now we call elevated blood pressure. So how do you diagnose manage childhood hypertension? So, oh, sorry. Yeah, so this is a table. I'm just showing a table. I don't know whether you use electronic medical record system, so you can get percentile automatically. If it's not, you use this AAP table. So let's say this is the 8-year-old, and then this is the boy, and this is a percentile for percentile for their height, and then this is the height inches. This is the height centimeter, and then you actually see the 50th percentile, 90th percentile, 95th percentile, plus 95th plus 12 millimercury. So this is going to tell us what percentile of the patient blood pressure is. This is a screening BP values. So you can have these tables in your triage room. So instead of looking at the percentiles and height and genders, it's all each age category, and only boys and girls have one BP reading, systolic and gastric BP. So let's say if your patient's in a boy and an 8-year-old, if the blood pressure is 107/69, and this boy's blood pressure is normal, so you don't have to look at the entire table to diagnose whether the patient has high blood pressure or not. So then, do we really have to measure BP for every child? So this has been changed. They used to be said every patient in 3 years or older, even healthy kids, and then for every visit, clinic visit, they're supposed to check their blood pressure. But now new guidelines say you only check annual blood pressure for 3 or older if the patient is completely healthy. You don't have to check for sick visit, but they recommended you for manual. So here's a BP measurement algorithm from the paper I just showed you for 2017 clinical practice guideline. So if the blood pressure is greater or equal to 90th percentile, and then you do repeat blood pressure twice and take average these readings. And if it's still high, the question is it done manually? If it's not, repeat manually. And then if it's still high, repeat 2 more times manually, and then record it for average these readings. And that's how we actually diagnose the clinic. So it's a lot of cumbersome steps. And then, so I guess many places may change from automatic machine blood pressure measurement to manual blood pressure measurement. So here's the evaluation and the management based on the BP levels. This is also coming from the article. So if it's blood pressure is normal, just to do for annual and then do lifestyle counseling. If the blood pressure is elevated, you can do initial. You might want to check the lower upper extremity blood pressure to rule out a coarctation or a mid-aortic syndrome. You might repeat blood pressure in 6 months and in the second time and another 6 months. Then if it is still elevated, you might consider having a ABPM, ambulatory blood pressure monitoring, or some diagnostic evaluation, and consider subspecialty referral. And if it's stage 1 hypertension, intervals for 3 visits will be less, more frequent, and then stage 2, you might actually refer to a patient to refer to subspecialty sooner. But if you ask me, so what's the best way to do evaluation for blood pressure monitoring? I would say obtain the 24-hour blood pressure ambulatory monitoring. So what is the ABPM? So this is the ABPM you can see that there's some cartoon. Sorry. The size of the machines just like that, they're small. And the patient wear for light wear monitors, and it takes the BP regular intervals for 24 hours. And then readings are recorded and then later download the data and for analysis. And the several equipments are available used in children's and validated in children. Not sure have you ever seen these machines? So things like so I guess it's the, I don't know, maybe I missed this one slide. So the so indication for ABPM is that identified sustained hypertension versus white coat hypertension, and identified masked hypertension, and then assess the blood pressure control with hypertensive medications, and then other elevated blood pressure in patients with high risk conditions such as secondary hypertension, chronic kidney disease, some renal structural anomalies, diabetes, solid organ transplant, obstructive sleep apnea, even obesity, coarctation, some of the genetic syndromes associated with hypertension, NET type 1, Turner syndrome, Williams syndromes. Patient born prematurity known have higher risk for hypertension, and of course the patient treated for hypertensive. So how does it look like for ABPM readings? You can actually see this is an example for the each vertical line shows the BP readings, and then top is systolic, and then bottom is the diastolic. And then we have a parameter for references for ABPM for kids. And then we have a systolic threshold when the patient's awake. And then we have a threshold for diastolic. And then also we have a threshold for sleep, is systolic blood pressure, and then diastolic blood pressure. So what we do, checking in the mean or average systolic blood pressure and diastolic blood pressure, both on awake and asleep. And also we look at the nocturnal dipping. And we expected the nocturnal dipping is about 10 to 20%. And so here's the BP categories that based on the clinic blood pressure readings and ambulatory blood pressure monitoring. As you see, so normal blood pressure, so let's say if the clinic blood pressure is normal and then the ABPM is normal, then we call it normal blood pressure. Let's say if the clinic blood pressure is greater than 95th percentile, or 130/80 for greater than 13 years old or older, then we do ABPM. And if it's normal, we call white coat hypertension. And surprisingly, actually, that we see significant patient referred to us for elevated blood pressure turn to be white coat hypertension. That means that the blood pressure is completely normal. So you don't have to investigate the further studies to avoid unnecessary the workup for these patients. And then this number could be up to 50%. So that's why I really want to have ABPM, 24 ABPM prior to for any further investigation. And the masked hypertension is the other way. Clinic blood pressure is normal, but when you perform ABPM, 24 ABPM, and they find out find out abnormal. And the masked hypertension doesn't happen in general for normal healthy kids. You might actually see a transplant patient, chronic kidney disease patient, other patient with some type of comorbidity develop the masked hypertension. And then it is just important to diagnosis because if you have a masked hypertension, it's actually the outcome for cardiovascular disease in adult known to be pretty high. The other one's ambulatory blood pressure, ambulatory hypertension, which is consistent, high blood pressures in the clinic, as well as confirmed by ABPM. So there's 4 categories we can diagnose based on the clinic blood pressure reading plus 24 ambulatory blood pressure monitoring. Okay, so I just want to touch a bit, talk about the cases of secondary hypertension. like I said, maybe 20 or 30 years ago, most of kids just diagnosed with secondary hypertension, but now majorities of the hypertension in our clinic is the primary hypertension. But of course, there's some differences based on the age group. The infant, still the secondary hypertension is most common. The reason that we see all those pediatric hypertension in nephrology clinic because of the secondary hypertension, etiology of secondary hypertension. For infant, the renal parenchyma is about 20%, renal vascular hypertension, and then about 25% of the hypertension in infant, and the coagulations another one. So there's a vascular renal issue that leads to the etiology, cause of the secondary hypertension for the infant. There's some endocrine neoplastic, a few percent. The school age becomes more primary. It's probably even higher than 15 or 30%. It's probably a lot higher once you get to age 6 or age 8, some in the first or third grade. And then secondary hypertension, still the renal parenchyma, renal vascular disease, the coagulations is the high top of the differential when you diagnose secondary hypertension. The other part is maybe pulmonary issues. If the patient has a chronic lung disease, preemie baby, you have some type of CNS disease, increases the intracranial pressure, could cause systemic hypertension. Some of the medications are also important to remember, and environmental exposure. There's rare monogenic hypertension with genetic syndromes, such as neurofibromatosis type 1. So talking about the drug-related hypertension, the over-the-counter, you see some decongestants, caffeines, NSAIDs, some of the alternative therapies and others and nutritional supplement may cause hypertension. So when you're taking the histories, it's important to talk about all those over-the-counter medications, including supplement. Some of the prescription drugs, we see the stimulants for ADHD patients, some of the hormonal contraceptions, steroids, and the tricyclic antidepressant. It's not illicit drugs, amphetamine, cocaine. These are going to cause high blood pressure, and environmental exposure, lead, cadmium, mercuries, and these may cause some high blood pressure as well. So then, how do you evaluate for hypertension? Like I said, my practice, I do first for 24 blood pressure monitoring to rule out what called hypertension first. I will send the urine sample to test to make sure there's no hematuria or proteinuria to concern about the renal parenchymal disease. Then, if you confirm the hypertension, you can probably send some of the chemistry, lipid profiles. And we don't now the recommendations, you don't have to do renal ultrasound to every single patient. You can just select a patient to do ultrasound. An obese patient, you might want to add some fasting lipids and glucose, hemoglobin A1C, and AST and ALT. And then some option, it could be checking the fasting glucose, viral function, a drug screen, a sleep study because it's always there, and then checking the CBC. Echocardiogram, this is a bit busy slide, but I guess it's assessed for cardiac damage. Now that the guideline says we don't have to do echocardiogram unless the patient's going to be pharmacological therapy. But what we look for is the LV mass and the geometry and the function. And then this is the definition we use for LV mass index, based on based on the height for 8 years old or younger, older. And then 51 is the adult parameter. And then now we are going back to see maybe we should use percentile to diagnose LVH. And for younger boys and girls, we use BSA for LV mass index calculation. So the repeat echo monitor target organ damage at the 6 to 12 months interval. If the patient has a persistent hypertension despite treatment and a concentric LV hypertrophy or a reduction of LV rejection fraction. ejection fraction. If the patient result LV hypertrophy, and then we may repeat echo annually if the patient has stage 2 hypertension or having a secondary hypertension or incomplete treated chronic stage 1 hypertension. So major point of this talk, this part talk was pre-hypertension. Now it's called elevated blood pressure, and the new normal pediatric BP tables based on the normal weight children. And there's a simplified screen table, so you can use it as a triage, and a simplified classification in adolescent, so you don't have to go through the percentile or height. We have a more limited recommendation for screen of BP measurement, just to use for healthy kids 3 years old. Annual check is enough. And the streamline for recommendation for initial evaluation and management of abdominal BPs, and reverse recommendation of echo and expanded role of ABPM. So the next part is that the blood pressure from childhood to adulthood. So now, this is the something, let's talk about the something we don't know so well. The questions of what happens when these kids grow up and they grow old. So here is the adult data from American Heart Association. And then if you look at the hypertension for different age, young adult to older age group, and then the males in the blue and the females in red. As you can see, even the 20 or 30 years old, they already have a 13 to 25% of the people are diagnosed with hypertension. And then of course, when you get older, it's a lot higher percentile. And they look at the cardiovascular disease, the incidence for cardiovascular disease for younger, these young 20 to 39, both in the female and in the male. If you don't have hypertension, there is very small number of the percent develop the cardiovascular disease. But look at the numbers, a percentile for cardiovascular disease under age 40 to develop if you have a hypertension. And then another problem is here is that so that if you just look at our awareness, and then the blue is that the young population, 20 to 39 years old, and then that the 41% of people even have high blood pressure. They don't know they have high blood pressure. And when it comes to treatment, the only 20% of patients are actually treated. And then whether patients' blood pressure is controlled, only 10%. So if you look, once you get older, it seems to be people are more aware of hypertension, and then they're more work on the treatment and have a better control. But we don't have the pediatric data here, but I assume that our pediatric data is probably close to young adult or even worse. So I expected that the kids with hypertension are often don't know they have high blood pressure, and then often untreated, and then even they're treated, often not well controlled. So does it matter? Of course, those kids are very rarely having a cardiovascular event, like a heart attack and a stroke. But we know that the kids develop the left ventricular hypertrophy. This is a marker used to target organ damage in adults. And then it also causes coronary intermediate thickening, arterial stiffness, and the retinal vascular abnormalities, and the kidney injuries, and the neurocognitive deficit. So here is the data. This table summarizes the 4 studies about LVH and children with hypertension. And as you can see, the prevalence of LVH is quite high based on a 95th percentile or even adult criteria. So some children have a concentric LVH, which is known to be associated with worse cardiovascular outcomes in adults. Another part is that the changes in the brain and the cognition, and it's been known in adults as well, But we know from the kids that decreased cerebrovascular activities in due to hypercapnia and hypocapnia, and the decreased attention and the working memory, and then hypertension leads to impaired verbal learning and a decreased executive function, and more likely to diagnosis of learning disability based on the hypertension. But the good news is that executive function scores improved after the good blood pressure control. So it seems to be reversible, not be permanent changes. So does childhood hypertension persisted into adulthood? The answer is yes. I'm not going to go through, but there are some tracking studies being done. And then yes, if you have high blood pressure in childhood and then predicted high blood pressure in adulthood. And this has been done. So that the further studies, because the longitudinal study is very hard, we have to follow for decades. But this is the great studies that published in, I think it's 2 years ago. It's called the 7I3C cohort, and then from 3 continents examine the total more than 40,000 children 3 to 19 years old in the 1970s and 80s, and then more than 20,000 of these individuals have been followed up into the adulthood. So this is the map and showing what study is being studied in the 3 continents. And then here's a summary of one of the studies. It was published in two years ago, and New England Journal of Medicine. You can see this is a childhood risk factor, and one of the G scores is systolic blood pressure. If you have a high systolic blood pressure in childhood, there's increases in fatal and non-fatal cardiovascular event in adulthood. And then other risk factors, smoking, and then body mass index, triglyceride, and the total cholesterol. And if you combine this, Z score is going to go up significantly higher. And then again, systolic blood pressure has been known an important risk factor. Childhood high systolic blood pressure predict adult cardiovascular disease. And then this is just to summarize the studies. Yes, if you have high systolic blood pressures in the childhood, increases mortality, non-mortality cardiovascular disease in the younger age. So the red age is less than 47.7, and then the dark is black is the older age. So that you can see the higher event, young adult cardiovascular disease associated with the childhood systolic hypertension. So what is the treatment goal? I guess goal is that the blood pressure is less than 90th percentile or 130/80 in the adolescent or 13 years old. And the children and adolescents with chronic kidney disease and the hypertension should be treated lower, and they recommended 24-hour mean arterial pressure less than 50th percentile by ABPM. So of course, how to treat adolescents with elevated blood pressure? Then first, always want to do some lifestyle and non-pharmacological intervention. For adult, we start using the blood pressure medications very early on, but we really want to work on the lifestyle and non-pharmacological interventions because we don't know really a long-term impact. I'm starting the antihypertensive medication for the young age. So that we do dietary modification. Dietary approach to stop hypertension, a DASH diet, and the physical activities, moderate and vigorous physical activity at least 3 to 5 days per week, and then a weight reduction, motivational interviewing, and intensive weight loss therapy, and then stress reduction. The pharmacological therapy indication is as follows: systemic hypertension, secondary hypertension, left ventricular hypertrophy, and the diabetes patient, either type 1 or type 2, and the persistent hypertension despite non-pharmacological measures. And the agent we use and the ACE and ARBs and calcium channel blockers and diuretics. So for girls, reproductive age group, We try to avoid ACE and ARBs because of this reproductive age. We try to avoid for any potential harms when you get pregnant. So that we tend to use the calcium channel blocker for girls. For boys, we use ACE and ARBs as a primary choice. And then, of course, if you have a diabetes, chronic kidney disease, the first choice is going to be ACE and ARBs. And then we don't use diuretics as the primary, but we could use it as a combination, particularly for the patient with obesity. So there's a couple of the studies. This is it's called the SHIP-HOI study of high blood pressure in the pediatrics, adult hypertension onset and use. And then recruiting about 500 adolescents from 5 centers. We're not part of it, but they do for prospective studies measuring for ABPM, ecovascular cognitive assessment, and then they're doing epigenetic studies. And then we started seeing that a lot of great information from these SHIP-HOI studies. Another study we are participating in this is Superhero, the study of the epidemiology of pediatric hypertension. We are part of programs, and we try to get some fundings from NIH and other resources. But we're doing a bioinformatics-driven retrospective cohort study, and then collect the data to find out what sort of how we're going to emphasize the importance of the diagnosis of hypertension, and then we can try to find who will be a high risk developing a cardiovascular disease in the future. So this is a summary slide. So what we know is that the pediatric hypertension is a serious increase in problem worldwide, and the cardiovascular disease is not only an adult problem. Lifestyle modifications is important. It really has a good impact as almost as the same as in blood pressure medications. And what we need are better understanding of the adult consequences of child hypertension, and then the better blood pressure monitoring. This is challenging to do manually in the clinic or asking for at home. There's always some variables. How do you accomplish what we need to do for controlling the blood pressure? And then precision medication for BP and cardio risk management. And then we're doing the same thing for every single patient. Maybe we have to tailor based on the sort of a characteristic of the patient, and then how to treat the patient. This should be probably individually different, but we don't have the data to what to do for individual high blood pressure patients and children. And then, of course, we need for better public health. This is one of the things I would like to have a public health awareness. And then also the reimbursement from the insurance company, because they pay all those echocardiogram and ultrasounds and labs, and, but we don't have much reimbursement to do for lifestyle modifications. Probably more important to do for preventive medicine rather than for the diagnostic test. So that, thank you for your attention for after your business hours, and we appreciate attending my talk. And if you have any questions, let me know.
Thank you so much, Dr. Yamaguchi. That was great. I did have one question come in, and the question was, are there any clinical trials that should be considered? And if so, where can I find out more information about those?
I'm not familiar with the particular clinical trials at this point for the medications, but if I find something, I'll let you know. There's a small studies being done, but it's not like the big studies being done recently.
Thank you. And then I've just got one more, and it says, what would prompt a patient starting a medication and then needing to either switch or increase their dosage of a currently prescribed medication?
So like I said, goal is the less than 90th percentile, or for the 13 or older, less than 130/80. So ideally, we like to have maybe getting a home blood pressure machine and then have them to check used to for twice a day for like 2 weeks and see how the blood pressure is controlled with current medication. Or we can do for 24 ambulatory blood pressure monitoring with current med, whether the patient's blood pressure is controlled.
Perfect. Thank you so much. Well, Dr. Young,
Yeah, one more thing is that I guess you're studying from a single medication, and instead of adding a new medication to go up to the maximum dose before you add it for new medication. That's what I usually approach for blood pressure control.
perfect. Well, thank you again, Dr. Yamaguchi, and thank you all for hopping on and listening to the talk today. As you can see, Dr. Yamaguchi's contact information is on the screen, so please feel free to reach out if you have any additional questions that we didn't get to or that you think of later. But just again, thank you for taking the time, and I hope you all have a great rest of your day.
Thank you. Bye-bye.
Thank you. Bye-bye.